Hello. Hi, welcome. Welcome to everybody. Here we are. It's nice to see you all at this virtual event. I'm Alison Campbell. I'm the Chief Scientific Officer of Fertility. And so just to let you know before we get started what you can expect for this evening, we're going to talk for about 40 minutes to try and give you some information. We've got some short informative videos. We've got a special guest, Professor Charles Kingsland. Some of you have sent questions in, so we're going to work our way through those questions at two sections throughout the event. And there's a private questions tab if you'd like to put any questions in there, or you can also put them in the chat. So either way, we will either get to them tonight, or else we'll be able to email you back with some responses. You can also email questions directly to events@carefertility.com. And if we don't have time, we will get back to you at some point. And also tonight we've got our new patient inquiry team around, so they'll be here till 8 o'clock, I believe. And the number to ring if you want to talk to them is 0800 564 2270. So we're going to start with a short video just introducing you to Care Fertility, and I shall be straight back after that.
Family. It's who we are and who we're always going to be. It's the important little moments, the big emotions, the beating heart at the centre of our world. It's the journey that we take there, together, one step at a time. Family is the one thing we'll always care about the most, because we believe that family is for everyone. And through our care, we'll do everything we can to make your dream real. We don't just care, we are care.
My name is Professor Charles Kingsland, and I'm the Group Clinical Director for Care Fertility. At Care, our number one belief is family for everyone, and this means we do everything possible to help everyone start or grow their family. We know that nothing is as important as family, and that's why we care so much about wanting to give every patient that comes to us their best chance of having a baby. Of course, families come in all shapes and sizes. We get heterosexual couples, couples of the same sex. We get single patients wanting to start a family. We get NHS patients. When you have a fertility problem, there should be facilities available for you to get the best advice and the best treatment readily available to give you the best chance of having a baby at a time in your life that is best for you. We will use all our knowledge and experience combined with highly individualised treatment, personal treatment, to help you have the family you are longing for.
Unbeknown to Gemma and I, we both carry a gene, a deafness gene. We actually have a daughter who was 3, but who was born prematurely deaf. And we were given the option and chose to go down a fertility treatment to kind of avoid our second child having that same gene.
We were very lucky in the fact that the clinic was only down the road from us, so we felt there was one around the corner. It had good reviews. We just felt it was good for us, didn't we?
The whole package made us just feel really comfortable that actually going with Care was the right decision.
So the team that we worked with at Care were unbelievable. They were caring, they were sensitive, they were compassionate, empathetic, and even when I was ringing out with I was feeling pains down one side, that the reassurance that they gave me, they honestly do hold your hand every single step of the way, and I feel like they lived the journey with us.
So I've had several treatments with Care, and I now have a baby, and that's taken a number of treatments, fertility treatments, different alternatives, different medicines to try and get it to work for me. I have always said I would recommend Care Fertility. I would recommend them for the comfort factor that I received, the friendliness, and just I think the word is my faith in care fertility.
So now I'm going to just go through a series of slides, a short presentation, which will hopefully help you get a better understanding of fertility and what we do at Care Fertility. So around 1 in 6 people need help starting a family. And at Care, we truly believe family is for everyone, and we help lots of different types of patients with a large selection of treatment options, very much depending on their individual situation. So during this event, we're mainly going to focus on the general IVF process, but whether you have treatment with your own eggs or own sperm, or donor eggs or donor sperm, the principles are generally the same. So hopefully you will find it informative. So there's a nice map of the UK, and as it stands, we have clinics all over the UK. You can see some of the main clinics with IVF laboratories, and some are satellite clinics that feed into our main clinics and work very closely with us. So with this arrangement, our patients can get the benefit and the knowledge pooled from a huge staff, a huge group of fertility experts, but within a local friendly clinic facility. So I think our patients get the best of both worlds. And it's really easy to get started with Care Fertility. This is Shah, lovely Shah, and we're going to hear from her a little bit later on. And we have a new patient general inquiry team. She heads up, really friendly and knowledgeable, and they can answer all your questions about treatment and about getting started with treatment at Care Fertility. If they don't have the answers, they know where to find them. And this is Alex. This is Alex in our London laboratory. And so getting the right diagnosis is really important, and it's key so that you get the best possible advice from the outset. And how we manage things at Care Fertility, we have a secure online patient portal. So we keep all the information relevant to your treatment there in one place. So if you've had any previous treatments or investigations, then we can upload that information. You can upload it into the portal. And so it's often not necessary to repeat tests, because we can see what's happened before and we can build your treatment plan based on that. So all of that information, once we get it into that portal, is reviewed by one of our consultants prior to your consultation appointment. And the next slide, we've got George. He's, oh no, that's the portal. The next slide is the portal, just to demonstrate how it works. So it's desktop, laptop, mobile friendly portal. So that's where we hold all your information and that you can access it. We can send information to you. And we get amazing feedback from our patients who use the portal every day. And this is George. He's one of our consultants. He's based in Sheffield. And so the initial consultation appointments are really very important start to your fertility journey. So our specialist will go through where you are in your current situation, listen to your fertility plans and your wishes, and go through any existing test results that you may already have had. They'll then explain whether or not we need any further tests. Sometimes we need extra tests to give us a clearer picture of how we need to go forward. And they'll discuss then the treatment options with you. And also, very importantly, the chance of success based on your own personal situation. So our intention is that when you go away from this consultation, you're going to have a lot of detailed information about the treatment options for you, so you can consider in your own time what you want to do next. So you'll know how and where to get support from our team, and you'll also be given any costs of treatment that you may have been discussing. So whether your treatment's complex or simple, we have the depth of knowledge just to help you start growing your family or starting your family. So of course, every treatment's different, and we pride ourselves very much in individualized treatment. And we start with very simple treatments like intrauterine insemination, and we progress to much more advanced, technologically advanced and complex treatments. So I'm going to just go through for a few minutes, walking through a typical pathway of IVF. Most of our patients require IVF, but many of these steps are relevant to other types of treatment, such as IUI or ICSI, or using fresh or frozen eggs, frozen or fresh sperm, donor eggs, donor sperm, or your own eggs and sperm. So I'll try and keep it general so that it makes sense for everybody. And so the IVF process starts with ovarian stimulation, and the first stage is to take control really of the hormones so that we can stimulate the ovaries to collect more eggs than you would normally produce in a month, which is generally just the one. Because if we can collect a good number of eggs, we increase the chances of creating a number of embryos, and then we can choose the best to get back into the uterus for a possible pregnancy. So everyone's issued with a medication protocol, which one of our nurses will explain with you, and they'll also show you how to administer a series of injections. We can also offer online injection teachers, so it doesn't necessarily have to be face-to-face, really whatever is preferable for you. So once we've started we've got the protocol, and we teach how to do those injections, and this is Di, one of the nurses, and she's going through how exactly the needles are attached, and the syringes are loaded and the injections are given. And you can see it's a very fine needle. Some people are quite daunted by it, but actually they feedback that it's very straightforward, and the teaching that we give is very comprehensive. So this is Rima here from Birmingham. So we've got people all over the country. We're all one very big friendly team, but here she is explaining how we go about monitoring. So each patient has their protocol, they know how to administer the drugs, and they use these drugs to stimulate the ovaries, and we need to monitor how those drugs are reacting and how your ovaries are responding to this stimulation protocol. So we do this by ultrasound scanning. So it's generally a transvaginal ultrasound scan. We can see what's happening in the ovaries, and we're measuring the number and the size of the follicles. And then we'll offer a final trigger injection, which will complete the maturation of the eggs. So it's a very important injection at the end of the stimulation phase, and it's usually given in the evening, and then your egg collection is scheduled for around 36 hours after that. The next slide shows the egg collection procedure in pictures. So here we use a very fine needle to aspirate, to use suction to take the fluid from the ovaries, from these follicles that are developing where the eggs are sitting. So it's really straightforward. It takes about 20 minutes, I would say, in a procedure room, and the nurse and the clinician in the theatre room using this needle to aspirate the fluid, which is passed through to the laboratory, where we can look down our microscopes and see if we've got eggs in there. And often the patients in the theatre will hear us shouting when we find an egg. So it's quite an interactive procedure. And the next slide shows sperm, and I think we've got a video we can pop up as well to show them moving. So sperm collection is usually taking place at a similar time to the egg collection. Now you can see the sperm swimming around on our slide there. So we're generally preparing the eggs and sperm at a similar time in preparation to put them together, usually early afternoon, to try and fertilize the eggs. And the method of fertilization is usually decided in advance, and it's based on these test results, including a semen analysis. So you'll know what you're expecting. And there are two main methods of insemination, of mixing the eggs and sperm. There's IVF, conventional IVF, which is in vitro fertilization, and there's also ICSI. So this is ICSI, intracytoplasmic sperm injection, and here you can see a very fine needle, which is 10 times finer than a human hair. We're using micro manipulators to inject that needle, which contains one sperm, into the middle of each mature egg. So it's an amazing technology, highly successful, and more than half of our patients have this ICSI procedure. The alternative is the IVF procedure. Here we can see that we've taken the eggs from the ovaries, and you can see the tube of sperm which has been washed and prepared in our laboratory, and we simply dilute the sperm to the right concentration and then mix the eggs with the sperm to allow them to fertilize overnight. So whether it's IVF or ICSI, it's generally performed in the afternoon of the day of the egg collection and the sperm preparation, and then the following morning, which is about 18 hours later, we have a look to see if they've fertilized. This is one of my favorite steps. So we go and look down the microscope and we can see two small nuclei if we've had successful fertilization. One is from the egg and one is from the sperm. This is Lena in our Nottingham team, although she's moving to Sheffield very soon to join that team. And we check to see how many have fertilized, and our embryologist will call you and let you know the good news. So following fertilization, we have embryo development, and here you can see the embryo developing. This is a time-lapse image of the embryo. It's taken every 10 minutes during the culture period in our laboratories, and we aim to perform the embryo transfer about this stage, which is the blastocyst stage, between 4 and 6 days following the egg collection. You can see here this one is trying to hatch a little bit, which is just what it needs to do for the implantation to take place once we perform the transfer. And most patients are fortunate to have several embryos, because if you remember, we stimulate the ovaries to get a good number of eggs. We try and fertilize all of the eggs, and we end up with a number of embryos. And it's really important that we choose the best embryo first time, and we've got several ways that we do that, and we are particularly specialized at embryo selection. So we have care maps, which when you saw the video before, that's the time-lapse system analyzing the embryos as they develop. It's unique to care. We've developed over a decade of research. We've developed algorithms to help us choose the best embryo. So we're very carefully using the time-lapse system. We're monitoring the timing that each embryo gets to each different cell stage, and then we apply our own algorithm, and it will give us an embryo score, and from that we will be able to tell you your chance of having a baby, and we will of course choose the embryo with the highest score and the highest chance of having a baby. We also, so this is the time-lapse device, so that's Alex again just demonstrating how that works. So the embryos are safe inside this incubation system, and the photos being taken regularly throughout the course of the culture period. Then we apply the algorithm. So this is a non-invasive method for embryo selection, which we call care maps. So highly successful and supported by a great deal of research that we've done in our own hands. So the alternative method that we are also highly skilled at for embryo selection is called PGTA, pre-implantation genetic testing for aneuploidy. So it's mainly used for women over 37 years, because as women get older, their egg quality declines, which means the copy number of chromosomes may be wrong. It's more likely to be wrong as the woman gets older. It's called aneuploidy. And aneuploidy can result in failure of embryos to implant. So what we can do is we take a few cells, and this is how we do this. We take a biopsy, just a few cells from the blastocyst, which has got more than 100 cells. It's able to spare a few cells. So we take just probably about 5 cells, and they're just snapped off carefully. We put them into a little tube, and we send them to a genetic testing lab. And that lab will count the chromosome numbers in each of the cells that we've sent and send us a report to tell us whether or not the number, there's the biopsy there, tell us whether or not the number of cells, the number of chromosomes is correct and euploid. If we can choose those embryos which have the copy number correct, then we have a much higher chance of success. And using PGTA then avoids us transferring embryos which are not viable. And even worse than not having a pregnancy with a non-viable embryo would be a miscarriage. So it avoids that problem, and it helps us to select the very best embryos with the right copy number of chromosomes. So you can imagine we've got quite a toolbox here. We can use our care maps for a morphokinetic analysis of the embryos using time-lapse information and our own algorithms. And we can also use PGTA with a biopsy, particularly for women of over 37, but there are other indications as well. Perhaps if you've had multiple treatments somewhere else, you might have had multiple miscarriages. So it helps us select the best embryo. So whichever treatment we think is best for you, we will talk to you in much more detail about it and give you all the options that are available. So once we have chosen the best embryo, then it's time for embryo transfer. So irrespective of how or which embryo we've chosen, we use the same method for embryo transfer. So the embryologist will load the embryo into a very soft catheter, fine catheter, and it's inserted through the vagina, similar to a smear test, but then through the cervix into the uterus, where we can just gently inject and place the embryo. So it only takes 10 minutes or so, and you can go about normal activities straight after that. So following the embryo transfer, we have what is commonly called the 2-week wait. And before you leave to go home, one of our nurses will explain what happens during that 2-week wait and give you a date for a pregnancy test. There's the embryo transfer in action, and then we have the pregnancy test and 2-week wait. So if the test result is positive, we'll give you an appointment to come back and have a scan, a pregnancy scan, so we can hopefully then see the heartbeat of the little baby. And if it's negative, then we offer support and we have counselling available, and we'll also arrange follow-up appointments so we can discuss how the treatment went and what you want to do next. So we move on to just briefly to talk about donation. We've got a really large team of donation and counselling specialists at Care. So we've got everything in place should you need to use donor eggs, donor sperm, or even donor embryos. Some patients donate their embryos for other couples, just as patients and people donate their eggs and sperm for other people's treatment. It's a fantastic thing. So our donation team have over 25 years experience, and they're able to support you throughout the whole journey. We might talk a bit more about donation with Professor Kingsland later. So just a couple more slides. So support at Care. So I just wanted to say a few words about the support that you'll receive. It's a very important part of your fertility journey, and we offer free counselling appointments, and we've also got a buddy programme. So some patients, it's very reassuring to be able to speak to other patients at the similar points of their fertility journey, so we can buddy you up if that's what you wish. We also hold online regular support groups, and we have a 24/7 online forum, so you can chat with other patients and professionals, and all of this is supported by our staff, of course. And we move on to Care Pay. So we're also here to support you financially as well as emotionally and medically. We have Care Pay packages, which are exclusive to us. They're individually tailored IVF funding packages. So they'll hopefully then give peace of mind at knowing that the plan is in place to fund your treatment if you're not eligible for NHS funding. And we do treat NHS patients as well. We have contracts for NHS treatments, but many of our patients are also self-funded. So we created Care Pay following patient feedback, so it's managed entirely in-house, so our patients have a more seamless experience and their treatments kept personal and private. So we've got 3 programs. We've got the Care Pay multi-cycle, we've got a refund program, and we've also got an egg donation related Care Pay program. So we're going to move on to our first Q&A section. So just a reminder, we have got the patient inquiry team here if you wanted to call them. You can put your questions in the chat or or by email, as I said before. So let's invite Professor Charles Kingsland on, and we'll go through some of the questions that we've received and any that have come through as I've been talking tonight. He should join me on stage very shortly. I'm back. We'll wait for he is.
Here I am.
Good evening. Good evening.
Good evening, Dr. Campbell. How are you?
I'm fine, thank you. Very well.
Very good. Very good. I've got a lot of questions here already. So shall we start going through them and then see how we get on?
Yep, perfect.
Okay, so as Alison said before, if there are any questions that we don't get round to answering now, we can always email. If you email them, we can get back to you later on. So can I have a fresh embryo transfer if I have PCOS? Well, PCOS is polycystic ovarian syndrome, which is an abnormality of ovarian function where you don't you produce lots of eggs of varying quality. And the reason it's called a syndrome is because it's a spectrum of disease or disorder from very mild to quite severe. Most people have very mild symptoms of the disorder, and it's very, very common. So can I have a fresh transfer after I have PCOS? Of course you can. As Alison...
Oh, it's disappeared. I'll carry on talking whilst we wait for him to pop back on. I thought his the quality of the picture wasn't the greatest. It might be his broadband. But yes, we can perform fresh or frozen transfer, and we individualize this. So it depends very much on the circumstances. We look at the endometrium, we look at the patient's history, and we discuss the pros and cons of a fresh versus a frozen transfer. But frozen embryo transfers are as successful as fresh transfers, and in some cases more successful. So we need to consider very carefully which type of transfer to undertake. But certainly the freezing program is highly effective. We use vitrification, which is a method of cryopreservation of freezing, and more than 99% of embryos that undergo this freeze-thaw process survive beautifully and implant as if they were fresh. So the beauty of frozen embryo transfer as well is that we can make sure we perfectly synchronize the transfer with the lining of the endometrium so that we optimize the chance of implantation. I don't know what's happened to him, but we've got another question here, which is, do you have any advice for using an early blastocyst? So blastocysts are the stage of embryo development where a cavity forms, a fluid-filled cavity forms, and the cell types start to differentiate. So we have two cell types within a blastocyst. There's the inner cell mass, which becomes the baby, and then there's the trophectoderm, the cells around the periphery, which become the placenta, and a fluid-filled cavity in the middle. So early blastocysts are those blastocysts that we're just starting to see the cells differentiate. The cells are starting to change. The fluid-filled cavity is starting to form. And it's absolutely fine to transfer at that stage. And in fact, we are highly skilled at selecting embryos and blastocysts because we have all of this experience with time-lapse imaging. So we know when we expect and when the best embryos will start to form blastocysts. So we actually see similar success rates if we transfer early blastocysts on day 4, which is not particularly common practice, but in our hands, because of the time-lapse imaging, we can perform blastocyst transfers, and they're usually early blastocyst transfers on day 4, as opposed to day 5 or day 6. If we have an early blastocyst on day 5 or day 6, it could be that embryo has a slightly lower chance of implanting because it is maybe a little bit delayed, because early blastulation should really start to take place later on day 4. But we can certainly map an embryo's development very confidently based on our desirable timelines. So we can give our patients a lot of information about the chance of success depending on the stage of their embryo and the day. the day of transfer. Charles is on his way back, I believe, but we shall see. So there's a question about how did we develop care maps? So this was the time-lapse algorithm that we spoke about earlier. So if you can imagine, over the years, we're monitoring lots and lots of embryos with this camera system, and we're recording the time that each embryo gets to each cell stage, so 2 cells, 4 cells, 6 cells, etc. And then the embryos are transferred based on traditional morphology, which is the way they look, the grade. And then we go back to the data and we can see, okay, well, all of these embryos were good quality, but why did these ones implant and these ones did not? And we did an analysis of the morphokinetics, so the timings that we've got from these time-lapse incubators. And based on that work, we have developed these algorithms. So whilst the embryos might look the same morphologically, they may all have the same cell number and they may be top grade, we can see how they got to become that grade and that stage, and use that data and that information to help us select more reliably. So it's a highly effective tool. Sounds really straightforward, but a huge amount of work and effort has gone into it, and it's very effective. So I'm just going to pop up some other questions that we've had whilst we still wait for Charles. We had a whole load in earlier. There was a question about egg freezing. So yes, we do egg freezing. We offer egg freezing, and we have a package called Egg Safe. And this aims to freeze around 20 mature eggs, because we calculated that for most patients, to give a very high and realistic chance of a family in the future, if they want to freeze their eggs for an insurance, really, then this is a magic number. So this is a very successful way to preserve your fertility if there's the cat, if the time isn't right for you right now to proceed with trying to get pregnant. So that's Egg Safe in a nutshell. Just getting up some more questions, right? Oh, there's a question about, is matcha powder safe during IVF? Well, I don't know much about matcha powder. It's a really good question. I would advise looking see if there's any literature, any scientific evidence, but I am not aware of anything. What generally, if Charles reappears, what he will say, oh, here he is, he'll like this one.
I don't know what happened. I'm really sorry. I don't know what happened there. I was trying my hardest, but it just all went blank. Oh. How did you get on without me?
We're doing fine, thank you. But we've got a good question for you here, and you'll like this. Is matcha powder safe during IVF?
Well, matcha powder is the leaf of a Japanese plant, isn't it? It's a tea leaf. Right. And if it's working for you, then absolutely, it's no problem. You carry on taking it, and it's fine. Did you do the mosaic embryo one?
Oh no, not yet. No, let's do that one.
Oh gosh. Let me just have a look. Oh, the day after embryo transfer, am I okay to go to work? Well, if you're a deep sea diver or a paratrooper, then probably not. But for the vast majority of people, it is absolutely fine for you to go to work and do normal things after an embryo transfer. Just be normal. Don't go mad. Don't just lie down and do nothing, but keep the blood pumping to your pelvis. Just do normal things, and that is what we expect. Because after all, if you conceive naturally, you wouldn't know that you're pregnant. So you just do normal things, and try not to worry too much. How likely are mosaic embryos?
Well, it's a good question, and if you ask a lot of different people, they'll probably give a different answer. So it depends where we set the boundaries. So most patients who have PGTA don't have mosaic embryos reported. So it's not a common phenomenon, at least with our genetics provider and where the thresholds are set. But what it means is, we were talking about the biopsy earlier and the PGTA. When we take 5 cells, if the genetics labs do the analysis and counting the chromosomes, and they find that 2 of those cells have an incorrect copy number of chromosomes, then that is considered mosaic. So the embryo has got abnormal copy number chromosomes and normal. So it's got a mixture. And from that, it is inferred that the rest of the embryo is probably the same. And it might sound scary, but it is generally seen that we can get successful, viable pregnancies that are normal with mosaic embryos, and particularly if they're low-level mosaic, like that example. So it's a big, complex topic, and if you are faced as a patient with a mosaic embryo in following PGTA, see the cat in the background, then we will go through it in great detail with you as an individual and talk about the discussion and whether or not to proceed with transfer and the chances of success, and what it means for you. So hopefully that covers the mosaic.
There's a lot of low-level mosaics like us walking around.
Probably are, yes.
Cheshire
quite
Merseyside,
right.
yeah. So the average timescale for an IVF cycle, start to finish, once you get started, it's about 3 weeks, really. The big issue about IVF is actually getting started. There seems to be an interminable time, from the time of referral to the time of the first consultation, and it can be very stressful. But once you start, it's actually quite quick. 3 weeks, start to finish on average. Do we test for NK cells? NK cells are natural killer cells, and this is one. Yes, of course we do, but this is one of those what we call, or what our regulatory authority call, add-ons. There is not concrete evidence to prove that unequivocally testing and treating NK cells will increase your chance of having a baby. It's not harmful, but as yet, the jury is out as to whether it's unequivocally beneficial. But we, after thorough counseling with your doctor or your advanced nurse practitioner, we will advise you whether those sort of tests, those add-on tests, are of benefit for you. And once you're fully informed, then it's up to you to make that decision as to whether that would be best for you, obviously with your doctor as well. But yes, we do. And we also have one of the world's outstanding clinics, actually, our Z2S clinic, where we are a real sort of international renowned center for NK cell technology. Is it possible to freeze eggs at 40? Well, yes, it is. It is possible, but whether it is successful or not, that's another question. And I'm sure Alison will be able to talk to that with more authority. But the younger you are, the more viable your eggs are, and then the more amenable they are to freezing and thawing. Would you say that, Alison?
Yeah, exactly. And that's coming back to this point about aneuploidy and the copy number of chromosomes being less likely to be correct as the woman gets older. We also see often a lower number of eggs being collected. So we've got the lower number of eggs being collected coupled with a higher proportion of aneuploid eggs. So it makes it more challenging to get a baby at the end. So it's possible. And I always like to think, well, if we give a patient a realistic chance, so let's say 8% chance of a baby, for example, I mean, we need more information to give a more accurate number, then it's really their decision if they think that's a chance worth taking, or if it's too much to undertake for that chance. I was going to say small chance, but for some people that's not a small chance, that's a chance. Yeah. So everything needs to be patient choice driven.
That's it. I mean, if your chance is given, and it's important that you are given a realistic chance, but if your chance is 5%, then that's your decision as to whether you want to embark on treatment with a 1 in 20 chance. Because if you're one of those 1 in 20 having treatment, okay, although your chances are low, it's better than 0. And so they're those difficult decisions that you have to make with the support of your doctor and the nursing team. There's one here. Is it possible to have a private consultation then go over to the NHS? Well, of course it is. But of course, you need to know whether you qualify for NHS treatment in the area where you live. Your local clinic, our care clinics, can advise you as to whether you qualify for NHS treatment and what the waiting list is. And it may be that you want, that might not be for you. If the waiting list is too long, you may wish to opt and pay for the treatment yourself. What you can't do, though, is to pay for private treatment and jump the queue. That's not an option. You can, if the waiting time for an NHS consultation is a year, for example, of course you can pay privately for an earlier treatment, because that's what you're paying for. But it doesn't mean to say that if you qualify for NHS treatment, you'll get treated quicker, but it might allay some of your fears and anxieties so that you can wait for your NHS treatment with more confidence.
Right, shall we hop up? We've got another short video, so we'll pop that on now, and then we'll come back for a few final questions because the time's pressing on. But here's a new video.
I'm Shah, and I manage Care's new patient inquiry team. We're here to make it easy for you to take your very first step in your fertility journey. We completely understand how nervous and excited you might be when you contact us. This is the start of a life-changing process and hopefully the beginning of an amazing future as a family. So it's really important that we give you all the information you need. That way, we can help you to feel much more comfortable and confident with your treatment. Whatever you need to talk about, I want to reassure you that no question is silly or trivial. We appreciate that there might be a lot to take in at first, but don't worry, we'll send you a clear information pack about the treatments you're interested in, and we're always here for any follow-up queries. My team also manage inquiries about Care Pay, our range of funding packages which are exclusive to Care Fertility patients. When you're ready, we can book you a virtual consultation with a specialist fertility doctor from your local care clinic. So, if you want more information, have a question, or wish to book an appointment, call my team. We want you to know that we are here for you at every stage of your fertility journey. We say that our patients become part of our care family, and it's true. We care deeply about you and your future, and our teams are here to make sure you have all the support you need.
The reason why we chose Care was just, one, the care that they give you, the aftercare that they have available to you, and the fact that they offer different forms of treatment, and they listen to you. One thing that I've identified and what I've noticed when speaking to other people that I've met within the infertility community is there's a lot of clinics out there that don't necessarily listen to you as the patient. It was kind of, well, one size fits all, but with Care that didn't seem to be the case at all. They took everything into consideration, and they listened to your concerns, they listened to you as a person, and they put a package and a process in place that will help you, and, you know, fingers crossed, will give you that positive result from at the end of it. So without a shadow of a doubt, if I had to go through it again, I would definitely go back to Care.
Oh, the support at Care was brilliant, yeah. I mean, the nurses were brilliant for us. You feel so
looked after,
cared for by the whole team. We felt that they did care, and it wasn't just for them getting something out of it. It was actually that
ongoing support.
Yeah, and they wanted it to work for us.
Care Fertility started over 20 years ago with one clinic and the goal of helping patients achieve their dream of family through truly personal care and the most scientifically advanced fertility treatments. We've grown from that one clinic we now have clinics across the UK, and many people have become part of our care family with over 50,000 care babies in the world. But one thing has and always will remain the same. We care for each and every patient. We care about your dreams of having a baby, and we put our heart and soul into every aspect of what care can offer you. To provide you with the best care possible and to give you your best chance of success and treatment, we look to our own care family. From our consultants, embryologists and nurses to our admin teams and specialist fertility counsellors, we've also put a lot of thought into how we improve each and every step of your journey, which will no doubt begin with lots of questions. We know that thinking about starting IVF can be daunting for some, and that's why our care, patient services and support teams will always be there for you whenever you have a question, need advice or simply want someone to talk to, so that you feel completely confident and in control of your fertility options. So yes, we have grown and developed over the years, but care and empathy are always at the heart of who we are. We are passionate about changing lives and creating futures, and I hope that this shines through in everything we do and everyone you meet at all of our clinics. We don't just care, we are care.
Did I see you get your wine topped up then?
Sorry, you saw that. It is 7 o'clock though, isn't it, Dr. Campbell? A little bit of wine is good for you. It's especially red wine. Not a lot, but 4 or 5 units a week. And when you're going through fertility therapy, it's this idea of no alcohol is to some people it's just not realistic, and it everything in moderation, as long as you don't go overboard. 4 or 5 units a week is absolutely fine. It certainly helps the stress levels as well in those small amounts, but not too much.
Right, good advice.
That's what I always say, Dr. Campbell.
Yeah.
Everything in moderation.
Yeah, that makes sense. We've got a question about PCOS. What protocols do we follow to avoid OHSS?
Well, nowadays we have protocols that can virtually eradicate OHSS, but girls with polycystic ovarian syndrome are at increased risk because of the risk of overstimulating. So what we do is, as the same with every patient, we individualize their treatments based on the history and the tests that we do. And what we want to do is to give the minimum amount of stimulation of the ovaries to get the optimum outcome and reduce the risk of side effects, but to maximize your chance of a pregnancy. And one of the innovations that we've developed at Care over the past few years has virtually reduced the risk of OHSS to such small levels that we can now confidently say the risks are extremely small.
Right. Can you tell us a bit about AMH? So lots of questions relating to AMH. So just general about low levels, high levels, and
AMH is one of the key tests that we do for any patient coming with a fertility problem. AMH stands for anti-Mullerian hormone. It's the hormone that's secreted by the little cells that surround your egg. So that the more AMH you've got, the more eggs you've got. The crucial thing is, though, it doesn't tell you about the quality of the eggs. It only tells you about the quantity. So it's much better to have a low AMH and be 20 than have a high AMH and be 40. That doesn't mean to say that we're not going to find good quality eggs when a patient is 40, but it's less likely than when you're 20. So AMH gives us a really good indicator as to what sort of eggs we are going to find when it comes to IVF. And in particular, it gives us an indication as to what drugs to give you and what dose, for how long and at what level, to get the best chance of getting the best quality eggs with the lowest risk of ovarian hyperstimulation syndrome.
Good answer, Professor.
Thank you.
Yes. What about recurrent implantation failure? So this is obviously it's a big problem. It must be very, very difficult for patients. What do we have in our toolbox to help patients with this problem?
Well, this is one of the beauties of working in the care family. We have 15 clinics and 25 satellites, and over 60 doctors who are dedicated to the care of patients who have difficulty conceiving, and each one of them has a particular specialty. So we have a recurrent implantation failure group. So that's where you put back apparently normal embryos, but the uterus, for whatever reason, just doesn't accept them and turn into a baby. And at that point, it may be worthwhile doing some tests on the uterus, the womb, and the lining of the womb, the endometrium, to see whether there may be an issue that prevents that healthy embryo sticking in to the uterus. And they're the tests of what we call recurrent implantation failure. Each individual clinic will have a specialist who will deal with that. And if there is a particular problem that they come up with, we have the whole network with expertise in all the clinics, say, for example, from Leeds right down to Tunbridge Wells, to London, to Bath, who will be able to comment and advise on that particular problem. It may be that you don't need any tests, but if you do, we can provide you with the best and most up-to-date information that exists. And then it's up to you and your doctor and your advanced nurse practitioner to decide where to go from there.
Are any of these tests accessible with NHS funding? Or
well, we go back to that story about evidence-based medicine. The NHS tend to rely very heavily on evidence-based medicine. That sort of those treatments that have been unequivocally scientifically proven. And that's fine. But every day there are new tests coming along of varying importance that may or may not in the future be of relevance. And I think it's important in the patient journey that you are made aware of that, but objectively from the consultant or from the clinic. There's so much information, very confusing information sometimes. What is that? Is that a dinosaur? No, it's a cat. Oh,
sorry.
It was like Jurassic Park for a minute. For most of us nowadays who actually, if we have an ailment, social media or Dr. Google is our first port of call. And of course, we're then greeted with a whole minefield of information of varying quality. Some of it is quite reasonable. A lot of it is completely rubbish. So we need to assimilate that information. The best place to do it is at your local clinic or your local care clinic, and you can come along with all your anxieties, all your information, say, look, I've learned about this, I want to know more about this, and then the consultant, the specialist, the advanced nurse practitioner can tell you what that information is and unravel that minefield and say, well, these are the benefits, these are the risks, these are the costs, and this is the potential benefit you will get from this test. And then once you're given that realistic information, then you can make that decision whether it's in your own interest to have the test and whether it's going to be any benefit to you.
Perfect. I think that's the great philosophy. We very much want our patients to make the decisions, to support the decision making and decide what's best. But exactly. Our toolbox is extensive, but I think we're pretty good at giving information in an understandable way. Some people want reams, some people want just a nutshell, and we can deliver it in different ways depending on whatever our patients want.
And we're all different. We all want different levels of information. We all want different levels of intensity. And at the end of the day, when fertility is such a high profile, such an anxious time in couples' lives, you just want to know the facts and what are the benefits to you as the individual couple. And that's one of the the great benefits of Care Fertility, because that's all we do. We do, you know, day in, day out, all the fantastic stuff you do in the laboratories, Alison. We are there to provide you with the best, the most up-to-date information we can, so at the end of the day, you can make the decision which is best for you. And that's not only the clinical decision, but it's a financial decision, because we all know that if you don't qualify for NHS treatment, or indeed if you do qualify and you want additional tests that are available to you on the National Health Service, what ones do you need? What are the ones that may be of benefit to you as the individual?
Right, good. And on that note, I think we're coming towards the end of the event, but we'd like to leave you with a message, some final words about care and how you can get in touch and learn more about us and book a consultation if you wish. So we'll get back to you with any answers that we've not.
1 in 6 people.
Right, sorry, just to say, yeah, we'll get back with any answers that we've not managed to get through everything, but we will get back to you with your answers. And remember, our team are available if you want to call. Thanks very much, and I hope it's been informative.
Bye, everybody. Good luck.
1 in 6 people need help to grow their family. You're not alone. And our Care family will do everything we can to help your dream of family come true. There are over 50,000 care babies in the world today. And behind this success is our promise to make more heartfelt dreams of family become reality by ensuring our care goes into everything we do for all our patients every single day. You will receive truly individualised treatment, a patient-centric approach with empathy at its heart. We understand how nervous and excited you might be about getting started, but you can be assured of kindness, empathy, and all the information you need from our new patient inquiry team. We are all here to make it easy for you to take your very first step in your fertility journey. Call our team on 0800 564 2270 to learn more and book an appointment. We don't just care, we are care.
Thank you. See you
Thanks,
soon.
everybody.